Okay, thank you, Nadeem. Dr. Mansoor, I will have 30 seconds because it's very difficult to hold Bilal there. I mean.
Okay, I can imagine. I think my age-old worry and question, even during my training days, late 70s, early 80s, we called cabbage as expensive analgesia until the data came out on 3-vessel and LV dysfunction. Now, what about the age? To me, age matters a lot. No studies cover the ages of 30s, 40s, and even early 50s, where these people are more pressure, they're younger, and what happens to them if you leave them with some stenosis, some disease? Do we wait for LV dysfunction to develop? Do we wait for CTOs to develop? That is a question that has not been answered so far. I'm not saying it should be done or it should not be done, but I think that is the population we need to look at, because there are more pressures to the society, young children to look after, their working population. If anybody has the answer to that, please let me know. Thank you so much.
Okay, sure. I think we'll go on to Bilal now. I think we'll have this debate later on. We can have further discussion on that. Bilal, you can hear me?
Perfect.
Okay. Bilal, can you hear us?
So by our measurements, the reference LED is like 2.
Okay, this is the other Bilal. So
this Bilal is here.
We want to go to PIC.
Bilal नाराज भी जल्दी हो जाता है ना?
Yeah, that's true. Yeah. So Bilal Murad, we're now talking about you, so don't worry about.
I know.
Okay.
5.35. 35 by 12. Just give me a second. I think I might give you. Do you want an Orserio by any chance? Do you want Orserio? Let me see if I have an Orserio. Come check Orserio.
Okay, Bilal, can you hear us?
15 is a little bit long. Yeah, yeah, no problem. Because balloon length is only 12. Okay. 12. So 12 or 15.
Hello? PIC. Bilal, can you hear us?
Again, good morning to the from the second lab.
We can hear you, but your image is static. Dr. Chan?
Hi, can you hear me?
Oh, okay. So we can hear you now, and we can see the angiogram image also.
Okay. Okay, let me invite our PIC team to introduce the patient history. Go ahead.
Okay, this patient, she is a middle-aged lady, 55-year-old, hypertensive, who presented with 11 days ago, presented with non-ST elevation MI. And during the admission, her angiography was done, which is shown over here. You can see, I think, on the screen, the spider view. There is a plaque in the distal left main, and there is ostial stenosis of the left anterior descending artery. Next view, please. In the epicaudal view, you can also see that the lower branch of the left circumflex, the OM, that is also stenosed. Okay, let us show you the views. This one, please.
So this is the 3O.
Okay.
Okay, over here you can see the epicaudal view where the second OM is subtotal occlusion. This is her ECG, and the ejection fraction is preserved, it's normal. So the case is open for discussion for the panel. So how would you like to proceed in this case? And I give over to Professor Chen again.
Yes, thank you. So I'd like to show the angiography from
Chen,
the
we
beginning
only
to
have 10 minutes with you, so can you quickly tell us what have you done so far?
Angiogram? Can you see? Yes, they can see. Okay. So from angiogram, you can see distal circumflex looks good. But you know, the side branch almost subtotal coated, and diffuse plaque from proximal circumflex to the middle pouch, and a very, very tight lesion at the distal, just distal left main. I think this is a very, very important case to show how distribution of the plaque from the distal left main into sunk flex and NAD. Once we have IVUS finding, we can answer this academic question. Next view. Next. Yeah, this is the IO cranial. So you can see also there is a long plaque distal to the first diagonal. But angiographically, it looks not very, very critical. Distal AD looks good. Next. Okay, this is a smart view. Clearly show the very tight lesion just at distal left main. So this is my colleague has done the predilation using 3/12 balloon. Next. So this is financial. Next. One more predilation, right? So this is the financial after predilation for AD left main. Because the left main is big enough, so I don't think a stereo balloon could minimize the plaque burden at the distal left main. So next, I think will be very interesting next. So I remove the wire from OM to the next. Yeah, from OM to the sunk flex. This is the BMW wire. Next. So then I use the 10/8 millimeter balloon to open the side branch. So this is the final shot to show the teaming flow in the side branch. It's a very, very good. Next. So we change it to use another two balloon. I think that now it's a it's a volcano IVUS cancer in the LD. So I'd like to invite Professor Anjung to introduce the IVUS finding from LD to left main.
Okay. So here we have got the IVUS run from the left main, LED to the left main, and we are showing you the run. So over here, this is the proximal LED, and now this is the pullback from LED into the left main. So over here you can see that it's a large left main. It's like a 5/0 vessel, and its left main itself is generally plaque-free, except at the most distal area. This one is the distal left main, and over here you can see some tapering and some plaque followed by, this is at 6 o'clock. You can see that over here is the origin of the left circumflex artery, and this one is the now osteal LED. And you can see in the osteal LED, this is the first IVUS run after the balloon, and you can see there is some plaque modification over here. And this one is the proximal to mid LED. Over here there is a eccentric small volume of plaque from 2:0 to 5 o'clock position, which is calcified itself, but there is no sphere disease. So with this, we'll calculate the reference vessel area over here by the dot method. You can see it's like a 3/0.
Yeah, picture.
So you can already see the calculations. The plaque burden, the proximal.
What do you say?
To mid LED is like only 16%. And
I think we need
reference
to
vessel area over here is 3 millimeters. And this one is the osteoproximal LED, where there is the origin of the circumflex. And this is the area where the plaque is mainly focused.
Okay,
Remember that this is the
take an opinion from our panelists here. Bilal Murad, I mean, you've seen the case. I mean, what would your approach be, and how would you take this case?
Yeah, you know, my concern remains that if you look from about 5 o'clock to about 12, there is this rim of darkness behind, and I'm concerned that there's quite a bit of calcification. And I know that the balloon angioplasty has been done, but if you look at it, it's fairly thick over there, and I do wonder if this would have been a case where some form of atherectomy may have been a little bit more helpful. If the balloon expands well, I think then it's reasonable to stent and post-dilate that, but we do still carry the risk that it may remain under-expanded slightly. So if you prepare for that, I think in my lab right now, if I had that kind of an appearance, I probably would try to do some. If I've already done a balloon angioplasty, sometimes lithotripsy can even help at this point in time. Or of course, in that setting, perhaps the OPN balloon or something, some high pressure non-compliant balloon maybe will help you.
Okay.
But I am concerned about the residual calcium.
Yeah, great. Thank you. Roxanne, I mean, how do you plan to go ahead with the case? What's your plan?
Can I ask, did they image the circumflex with IVUS?
No, I did not do. I did not do. I was a circumflex because I don't want to touch circumflex at all. So usually I did not want to do. I was for circumflex. So after we got information from IVUS from right to left main, so we decided to show the standing inflation angle. So we decided to use 3.5 by 12 next. Yeah, next.
I agree with Bilal's thing that the calcium burden is quite heavy and it's almost 360 degrees. So you would want to dilate this or shock wave this or something to make sure you've modified it.
Yeah, actually, from IVUS, even there are some classification, but I do believe the classification arc is less than the 270, and also the classification thickness looks like not too much. So I think it's expandable. So next, this is stent, right? So can you see the angiogram right now? Previous one. Hello?
Okay.
Can you see angiogram? Okay. No. Next stent.
Yeah, Roxanne, I think we are short of time, so what we're going to do is we'll go ahead with our debate, and then we'll come back to you to see the results once you are finished.
Okay, can you see angiogram? This is the stent in the position, just proximal to the first diagonal, to the very proximal left main. So from angiogram, you can see this stent balloon was fully expanded. Next. This is the shot immediately after standing. Obviously, even this is a 3.5 stent, but according to the IVUS proximal ID reference vessel diameter is around 3.0. So I dare not to inflate this stent at very high pressure. So this is why no more change at the distal left main. Because the left main is pretty short. So the 12 millimeter in length of the stent could almost recover the whole stent. So I think the next step is very easy. After remove the gel wire from circumflex, you see from the epicaudal, no more change after stent for the circumflex.
Okay.
So now I change it to use the 4.0. This is the 4.0 non-compliant balloon.
Roxanne, Bilal.
Hi, Xiaoliang. This is Huaiqing here again. I think this case reminds me of the previous case that you did, so I agree with this provisional approach here. And I also don't think that we need to do anything about the circumflex, and I also don't think we need to do anything about the calcium. But what is of concern to me here is the differential difference in the diameter of the left main and the OAD. This stent of yours hopefully can be expanded well enough to maybe close to 5.0, because not every stent can be expanded to the extent. So there are very few stents in the market that can do that. So hopefully the stents that you use is capable of being expanded all the way to that of the diameter of the left main.
Okay, thank you. Roxanne, we're going to come back to you to see the results. We are going to go ahead with the debate. We'll come back to you in about 10 minutes.
I fully agree with you. Okay. Because, as I said, the proximal ID stent is only 3.5, inflated by 8 atmosphere. Because, I don't want to put 3.0 stent because left main is pretty big.
Mute yourself,
so after that, why I used first I used the 4.0 balloon to post-dilate distal left main as well as proximal ID.
Dr.
Is
Chen,
that clearly?
Dr. Chen.
So after the first post-dilation, I will change it to use another 5.0
Okay,
balloon.
Dr. Chen,
Yeah.
Dr. Chen, we are going to come back to you.
Previous one.
Bilal, can you hear us?
Yeah.
We are going to come back to you in a few minutes.
So the The balloon diesel mark.
क्या ले जाऊं हॉकी स्विमिंग चलो
I
नहीं
can
भी
see.
होगी बेटा फिर धक्का होगा
Can you hear
There's
us?
a lot of
मम्मा को कुछ
noise
कराने दे
interference.
डिसअपॉइंटमेंट
Can you hear us? Okay. Okay, so let's go ahead with the debates.
Okay, I think we'll go back to the lab to see how things are going. We go ahead with the last debate, which is about aortic valve replacement, percutaneous or surgical. And we have two excellent speakers, Dr. Hakeem and Dr. Saulat Fatmimi. So first will be Dr. Hakeem speaking in favor of TAVR. Dr. Hakeem.
நம்ம ஃபர்ஸ்ட் பிஜிஸ் போடலன்னு சொன்னதுக்கு ஆனா அந்த அதை கேட்கவே இல்லை
Pass बंद कर दो यार. So I think the quality of transmission is now good. Now I can hear you very clearly. Previous. So I use this is the 4O NC balloon. I like to explain one more. So from
O may not be large enough for those.
Thank you, Dr. Chen. I think you can put my slides on. Thank you for the opportunity. I just feel a bit sorry for my mentor and teacher, Dr. Saulat Fatmimi. He's seeing left mains being done by interventional cardiologists, so I think this is not good timing. All right, so this was somewhat of an emotional talk for me. Last year, this time in the U.S., we had moved on to doing Tendyne for severe MR. We had moved on to doing mitral clip, tricuspid clip, and then Jenna valves for severe AI, and then Evoke for severe tricuspid regurgitation, and then M3, a fully percutaneous TMVR for severe MR. And then this case that I did shortly before coming, where we did a combined TAVR as well as a transapical Tendyne in the same setting. And then I am preparing this talk, and I just couldn't help but get emotional about how much love our cardiac surgeons have for malaria and polio and other considerations that we have in our society. So in 2020 and 2023, we should really not be discussing whether transcatheter therapy for structural heart disease is something we should be debating. So how did we really start in the U.S.? This is 2012 when the devices got approved. We put together our experience, and you can see amongst 10 highest volume centers, we were only doing about 15 to 20 TAVRs. And as time moved on, now in 2020, there's 701 centers in the U.S., and close to 75,000 TAVRs are being done. And as you can see, the mortality has exponentially reduced over time. If you look at the risk categories, it's being done essentially across intermediate to high-risk patients, and transfemoral is really the standard of care now. If you look at the median duration of stay, that has gone down from a week to about 2 days. If you look at the pacemaker rate, that is less than 10%, but mind you, in the US, about 70% of valves are balloon expandable. This is most recent data, and this should be eye-opening. Just published about 5 months ago. This is the patterns in the US as of 2022. And what is most striking is the age group of 65 and less. Half of these patients are now getting TAVR. All right, forget patients above the age of 65, but patients less than 65, half of them are getting TAVR. Let's talk about AS. We know 12% above the age of 75 will have AS, and 3.4% would be severe. In autopsy studies, it's almost 10%. In Pakistan, a population of 250 million, a median age of 19, we only have 3.7% of our population above the age of 65. We don't have any data. That translates to 8.5 million people above the age of 65, and only 1.4 million people above the age of 75. So roughly, based on the math, we have 47 to 50,000 patients who would have senile severe AS. This is data from NICVD, the first 100 consecutive TAVR patients that were done. This got published about 2 years ago. Half of them are bicuspid, majority were with a first-generation core valve, and it's not surprising that 10% of these patients required a double valve. About 15% risk of major vascular complications. Successful valve deployment was in 95%, and the in-hospital mortality was close to 8%. About a quarter of the patients required a permanent pacemaker. This is recent NICVD data since we restructured the program in November. We've done about 21 TAVRs. These are all intermediate to high risk, and they're essentially all surgical refusals. There were 5 emergent cases that we did. 4 were done on a weekend. They're all evolute Rs. The median age is 76 years. Median hospital stay, 2 days. 1 in-hospital mortality. 1 permanent pacemaker. 1 patient had a minor CVA and a non-disabling CVA or receptive aphasia. No vascular complications and no cases of moderate or severe PVL. So I don't need to convince the crowd. When you see 8 randomized clinical trials published in the New England Journal across the entire risk spectrum, this is for the balloon expandable valve, and then this is for the self-expanding valves. There is no doubt that not only is TAVR non-inferior, but I would argue it is superior to SAVR. 2-year outcomes of the low-risk Edwards trial, it shows a consistent benefit. And these are hard endpoints. We're looking at death, stroke, or rehospitalization in favor of TAVR. And this is just published this week. The Evolute R low-risk study up to 3 years in low-risk individuals. TAVR is superior with an absolute risk difference of about 3% across all subgroups. Now, why is it viable? This is a case we did last week, a 67-year-old severe LV dysfunction, critical AS, type 1 bicuspid valve. No surgeon wanted to touch this patient. You can see he was able to mount a mean gradient of 65, and you can appreciate the calcium. We did hemodynamics, and it was impressive that his intraventricular pressure was close to 200. We did a BAV, after which he got severe AI, had to be intubated, and then within a matter of seconds, we deployed a 29 millimeter Evolute R with good expansion. And right on the table, you can appreciate the recovery of LV function. We started with an EF of 15%, and now the patient has an EF of 50 to 55%. There's only trace PVL. So yes, there are issues with future coronary access. Right now, we only have Evolute R, but there are other platforms that are more forgiving. The pacemaker rates is a real problem, and durability. But I will admit to you that data from the Notion trial actually shows more structural valve degeneration with the surgical bioprosthesis than with TAVR. Now, final thought. These are guidelines, and the guidelines are predicated on the assumption that an average 65-year-old is going to live 20 years. In our population, less than 3% of our people would survive beyond 65 years. So we really need to consider these things. And finally, I have 2 questions from my surgical colleague. If cost was not an issue, would TAVR be first line? And then, if surgeons had an equal buy-in, just like we do in the US, would TAVR be first line? And then, is it appropriate to call SAVR Dino-SAVR? Thank you.
Okay, thank you, Hakeem. And now we have Dr. Saulat Fatmimi talking about value of SAVR in Pakistani population.
Can we put my, yeah. Ladies and gentlemen, friends, Assalamu alaikum. Thank you very much for inviting me. So my topic is TAVR versus SAVR, which one is the best approach for Pakistani population. I have no disclosures except I am the only cardiac surgeon, maybe the only cardiac surgeon sitting with all the interventional cardiologists. So please don't beat me up at the end of this presentation. Surgical aortic valve replacement has been there for 60 years. And for the last 45 years, there have been great generation aortic valves. Millions of valve replacements have been performed with less morbidity and mortality, less than 2% in best centers. And we have had superb long-term results. Rather, if you look at all the meta-analyses, 80% were free of disease at 15 or 20 years with mechanical valves and even with bioprosthetic valves. So, but this was invasive, and high-risk patients, especially older age group, were not offered surgery. And we all were living with the fact that these patients probably will undergo a medical treatment and they will live their lives. That led to the invention of TAVR, and it literally redefined the lives of inoperable patients. The Partner 1 trial came in and it compared the TAVR with the medical management, and as you can see, that with the STS score of 11 and 12 and the Euro score of 26 and 30, they showed that if you operate with the TAVI as compared to the medical treatment, you're better off. And those patients did very well in terms of death, stroke, readmissions to the hospital, heart failure. They all did very well. But what happened? The cardiologists and a lot of people got bolder. They said, okay, we can do it on all these sickos, so why not try with a lesser group? So then came the Partner 2 trial. And they again showed, now look at, I just want you to look at one thing, which is, ye pointer kis tarah karna hai? Okay, look at the age. Look at the age there, and I'll come back to that later. But then the STS score was obviously now instead of 12, 15, Euro score instead of 26, 30, they've cut it down to 5.8. Now this is the intermediate risk. And they showed that if you operate on intermediate risk patients, you're still okay. And they compared this with surgery. And they looked at the morbidity, the mortality, the all-cause mortality, the MIs, rehospitalizations, everything. They all were almost comparable. And it's just everybody got flabbergasted. Ye kya hua? What is going on with the intermediate risk? Again, this is happening. However, most of these patients were in the 80s. Remember this. And this were intermediate risk. And the follow-up is not more than 2 years. But then the cardiologists even got bolder. They said, oh, we were able to do it on high risks, intermediate risk. Why not do it on all of them? And that's where the Partner 3 trial came in. And with an STS score where we used to operate on, they started operating on STS score of 1.9, which is like less than 2% risk of surgery patients. But the age range, again, look at the age range. And they showed over a year of the trials that there wasn't much difference in strokes, in terms of rehospitalizations, in terms of any cause mortality, and they were all okay. But this is about a year later. So it's a 12-month, even up to 2 years, they showed there wasn't much of a difference. And then the Evolute trial came in, and it also showed the similar thing, that with the STS score of 1.92, with the age group of whatever it is, they showed that there wasn't much difference. Actually, TAVR did better than the surgery in most of these people in 2 years. So up till then, the data is absolutely correct. I agree with this data. But what happens? That the TAVI or TAVR matured into a standard treatment option for severe aortic stenosis across the whole spectrum of risk. So it means high-risk patients, intermediate risk, low risk. Everybody can get TAVR. So that raised some very big questions. One was, is TAVR going to replace SAVR? Which patients should be referred for surgery in the era of TAVR? Are patients in Pakistan with aortic stenosis the same as in the West? Is TAVR going to revolutionize the treatment of aortic stenosis in Pakistan? What is the durability of these tissue valves in Pakistani population? And is the treatment cost effective for Pakistani population? So answer to the first question, is TAVR a superior approach for aortic valve replacement in inoperable or high-risk patients in Pakistan? Obviously, yes. There's no question about it, because we are not going to operate on them. They were living their lives, jitne bhi ek aad 2 saal, they were living their lives, whatever time they had, you change the life, and I totally agree. So whether you are a surgeon in the US who is also doing a TAVR, or you're a cardiologist, or you're a cardiologist or a surgeon in Pakistan doing a SAVR or a TAVR, I would prefer a TAVR here, and irrespective of whatever anybody says. But is TAVR a superior approach for aortic valve replacement in all anatomical variants in Pakistan? The answer is no, because if you have very severe leaflet calcification, especially in the raphe, if you have severe LVOT obstruction, if you have a small membranous septum, conduction blocks, horizontal aorta, if you have low-lying coronaries, femoral access is difficult, if you have a bicuspid valve, especially with severe calcification or an aortic dilatation, you can't be operating on all of them. And so the answer to all anatomical variants is no. So obviously, SAVR is going to be sticking around for all those other patients. Then the third question comes in. Is TAVR a superior approach for aortic valve replacement in low and intermediate risk patients in Pakistan? The answer is no, obviously no, okay? And why do I say that? Because there's a flaw in the Partner 3 and Evolute trial, and the results cannot be extrapolated to us. So what they said was, kaise karna hai guys? Okay. So the flaw is, less than 5 to 7% of patients in these trials were less than 70 years old. In Pakistan, most of the people that they're getting their aortic valves are in their 20s, 30s, 40s, and 50s. The bioprosthetic valves are not durable. They're not recommended for patients under 60 as per the current ACC or the European guidelines. But we may be putting it in, but they're not recommended. So if there are no contraindications, younger patients would just get a mechanical valve, hence TAVR is not recommended. And there is also accelerated degeneration of bioprosthetic valves in South Asian population. Whether you agree it or not, ask all cardiac surgeons or cardiologists in Pakistan. They will say there is an accelerated degeneration. We don't have a result, but that's what we feel. Then the second thing is, a majority of Pakistani population have rheumatic heart disease or bicuspid valves. That's a different pathology as compared to the West those trials came for. And these TAVR trials were conducted in a country where the pathology was totally different. So all these TAVR trials were also done in rich Western nations with insurance plans or health coverage. Should I close my eyes and say that I am in Boston or Long Island still, or I am in Lahore or Karachi or Multan? So SAVR in a low or intermediate risk group costs 8 to 10 lakhs, $3,500. Okay? The TAVR in a low or intermediate risk group costs about 45 to 48 lakh rupees in AKU right now, in a private setup. So that's a lot of money. So what I conclude here is TAVR a superior approach for aortic valve replacement as compared to SAVR in high risk group? Yes, obviously yes. But is TAVR a superior approach for aortic valve replacement as compared to SAVR in low and intermediate risk? No matter what the trials say, no matter what the data is flawed because it takes older patients, not looking at the Pakistani population. The answer is no. Thank you.
Okay, thank you, Saulat. Hakeem, you have opportunity to say anything if you...
Thank you, Dr. Fatmimi, and I can't tell you how happy I am to see your romantic orientation towards TAVR. That has evolved over time. You make some very important points. Yes, I'm not advocating for anatomic subsets, which are going to be an issue, because see, understand, now we're doing younger patients, so lifetime management is a real issue. In Pakistan, I say we should only do a TAVR when a surgeon says, no, I cannot do a SAVR. That is how we've done every single patient in an ICVD. A surgeon first must say, I cannot offer him SAVR. then I think TAVR is a viable option. Thank you.
Okay, yeah, sure, please.
I would like to also add one other special surgical perspective on TAVRs. I don't know if anyone in Pakistan has actually explanted a TAVR in order to do a redo surgery. So whenever we are in AKU, we are always standby surgeons standing in the cath lab. I always have always thought, what a scary moment would it be if I had to explant it. So in the long term, you can't explant these things. In order to explant that, you have to do an aortic root replacement, which is a humongous surgery. So that's another drawback in a younger population. In an older population, which is already have crossed a certain age, for them, we are never doing a redo, or we are going to do a valve-in-valve. For these, I personally think SAVR just stays as a viable option. Nadeem.
Can I make a
point? Very short, I mean, less than 30 seconds.
जो आपने पहले slide दिखाई ना कि this was the argument which was put in the cost कि यहाँ तो पानी पीने को नहीं है तो या नहीं वैसे जनरल. So the medical fact is that if all those slides that you showed, SAVR is as good in everyone. In 2 years. The cost is a different issue. Cost to the laparoscopic surgery hai, that costs 5 times more than open. Okay. So I think the cost should be taken out.
We can't have a debate here, so I think we can make a point quickly.
That this point is not valid. The price will only come down with volumes. So if it is medically indicated, even in low risk group, one should do TAVR and the prices will come down.
Yeah. Okay, I think last comment from Dr. Nadeem.
I just have a point.
I'm going to come back. आपके पास आ रहा हूँ उसके बाद.
I just wanted to make a point. I hope Hakeem Yafi is still there. I really appreciate his talk because we at NICVD do 27,000 angioplasties a year. Last year we did, in 2022. Now we have stopped doing elective angioplasties from public grant. We will do elective angioplasty only somebody wants to get it done privately. Because I think the evidence is very clear that elective angioplasty should only be done when the medical treatment fails. We have a heart team that sits down, decides that patient has been on maximum medical therapy and still symptoms are there. Then we will do elective angioplasty. Otherwise, we only do primaries and acute coronary syndromes. So we already changed our practices. I don't think that the public sector money should be used where the indication is not there. And now evidence and indications are very clear. So, still saying that you do angioplasty in somebody who has a lesion, a 40-year-old, a 35-year-old, doesn't make sense. The evidence is very clear. Thank you.
Okay, thank you. We're going to come. Thank you very much for being so patient. I think maybe we'll start from Dr. Harun.
Just a small comment about the TAVR-SAVR debate.
Yeah, I think I think they have their right first, so let's hear them first, I think. So, can you switch on the mic? Yes. Yeah, okay.
I wanted to ask Dr. Saulat about the minimally invasive surgery in patients with aortic valve. Can he delve on that? And Abdul Hakeem, if I can have your attention.
So I think if you can give your comments here on whatever we have talked about, and we can have these question answers later on because we are short of time. We have to move on to the cath lab also. So Dr. Harun, you have any comments to add?
Well, there was an earlier case presentation about there was a lot of controversy. Although guidelines are there, but I think it's a very delicate matter and very common disease of culprit shock was being discussed. And that was that should we go for non-culprit lesions in people with cardiogenic shock and presenting with acute MI. So, of course, the guidelines are there, but still I feel that there is a subset of population, like people who are in cardiogenic shock and you open the culprit vessel, but the patient is not responding. The ischemia is also there, and he has a triple vessel disease or she has a triple vessel disease, and there are significant stenosis in other vessels. What I feel is that we should go and open up those vessels as well. And a lot of small studies have come up with this, and they are the results are very positive, that even during cardiogenic shock, if you treat the non-culprit vessels, the prognosis is improved. The mortality is decreased.
Yeah.
So we should have an individual approach as well for these subset of patients.
Yeah, agreed. I think these debates are debates because things are not settled yet, so you have opportunity to practice, I think, as the patient merits. Dr. Mansoor?
Yeah, well, I think following SAVR, my concern would also be with regards to anticoagulations, because particularly in Pakistan, since you have been talking so much about in relationship to Pakistan, I think anticoagulation is a serious matter. Under anticoagulate and over anticoagulate both, and there is a definite mortality related to that. I think we need to organize that before we actually popularize SAVR over TAVR. Thank you.
Okay, thank you. Dr. Ejaz, you have any? Okay, Dr. Shahzeb?
So I agree especially with Dr. Nadim, especially for the PCI and the symptomatic patient in stable ischemic heart disease. Regarding the prognosis, there is a bit doubt area that whether it improves prognosis, but most of us can review the symptom. One of the slides is Professor Nadim Rizvi Saab showed that if we just gave the morbidity benefit, especially for the hip replacement and the knee replacement, similarly is the case of the PCI for the patient symptomatic relief. Regarding the TAVI, we do offer TAVI in the Peshawar Institute of Cardiology just for the surgical turn-down patient. Almost we agree, especially from the KPK, that we will do TAVR only for the surgical refusal, because as far as the TAVI and the low and intermediate risk patient is concerned, still the SAVR is better. Thank you.
Okay, thank you. I think last comment, Dr. Shahbaz. So
Yes, regarding the TAVR-SAVR debate, I think in the last years, only a couple of hundred people have TAVR done. But this thing needs to be seen for the Pakistani population, because their aortic roots are generally small, even the older age, and surgeons do enlarge the aortic root. So how they are going to deal with this problem, Dr. Hakeem, what do you suggest?
okay, I think we won't have a debate here, so I think they are all valid comments, so I mean, there can be question answers. So we'll stop here. I'll thank you all the panelists here and those who have been here with us virtually, and all the speakers as well. Thank you very much, and over to Dr. Bashir for the next session. Thank you.